morning, everybody. Welcome to Surgery Grand Rounds. There is no commercial support for today's program. Any financial relationships of the planners and speakers with commercial interest have been mitigated. A link to the evaluation will be passed out and posted in the chat. If you are ABS certified and want NGHS to report your CME credits to ABS, please fill out the evaluation and give us permission. If you have a question for the presenter, please hold until the end of the talk. If you are attending virtually, you may enter your question in the Q&A section and we'll read it aloud. And now it is my pleasure to introduce our speaker for this morning. Dr. Daniel Whitson is excited and grateful for the opportunity to give general surgery grand rounds at his hometown hospital here in Gainesville, Georgia. It has been an unforgettable journey through general surgery residency at Northeast Georgia Health System. And with the help of his mentors, he is now looking forward to his next destination in Kansas City, where he will be furthering his passion for vascular surgery as a fellow at the University of Kansas in 2026. Please join me in welcoming Dr. Whitson.
Well, thank you everyone for coming this morning for Grand Rounds episode number 2 with Daniel Whitson. We're going to get into some really exciting stuff today, so just buckle up and get ready. We're going to start with a disclosure statement. I don't have any financial disclosures, but I will make another disclosure that unfortunately I just finished a trauma shift at night, and the day before the apartment building decided to violently pressure wash my apartment from the outside. So just hang in there with me. It might get a little weird. Some objectives we're going to go through today is we're going to review the history of pulmonary embolism diagnosis and management. We're going to discuss some recent literature and its influence on current management strategies, and we're going to understand some evolving treatment algorithms and their future directions for the management of PE. So this massive anaconda that you see before you was removed from a patient by a world-renowned cardiothoracic surgeon named Clifton Hastings. All right, and this actually happened at our facility. This is a huge saddle PE that was actually removed with a traditional surgical pulmonary embolectomy. So this can just show you, how this can be such a devastating disease and how it can kill so many people, just by looking at what is actually, being removed from these pulmonary arteries and affecting a patient's system. So to get into some history, no grand rounds would be complete without some, interesting history facts. So when looking at, the diagnosis and kind of discovery of PE, it kind of starts around the 1800s. That was really the time they started kind of seeing evidence of first hemorrhagic pulmonary infarction and then kind of working their way back with autopsies. It was throughout that century that they were able to develop the theory of clots within the pulmonary arteries that were there before the patient had died. And so that's when they started more aggressively trying to determine and investigate how those got there, what the mechanism was behind that process. So you can see Virchow is obviously named here. Virchow's tried for having thrombosis and what the risk factors are for that. He definitely played a role in discovering this as well. So this absolute legend, which I'm sure you're going to recognize, he was actually the first guy to witness a patient die in front of him from what he hypothesized was a giant PE, which they confirmed after with autopsy. And he started working on calves actually to develop a procedure to prevent this from happening. And so he was using a left peristernal incision to surgically remove the embolism from the pulmonary arteries, and although he had yet to test it on a patient in a real case. So it all started with him as far as the management of this in general, even before anticoagulation or any medical management was initiated. So that's, I think, a really important step in this whole process. So one of his students, Dr. Kirshner, witnessed unfortunately some unsuccessful attempts at this, and he was actually the first one to perform the successful procedure himself in front of a lot of colleagues. And so I believe it was a patient who had undergone a routine hernia surgery and developed a postoperative PE and was successfully saved during using the procedure developed by Dr. Trendelenburg. So in the audience that day was someone named Dr. Oshner and Alton Oshner, and so he was so mesmerized by this, the papers that came out really, stimulated the whole scientific community, that they actually, in almost every surgical procedure, they developed a cart that was for the removal of pulmonary emboli if it was to occur. Now, unfortunately, they did the procedure around 300 times in the next few years, and only less than 10 patients total even survived those procedures. So very poor, success rate. And at that point, Oster even commented that this procedure should essentially just be left to history and not attempted anymore. But going forward, we have this gentleman, Mr. John Gibbon Jr. So he also witnessed an unfortunate event where a patient expired from a massive PE, even though there was an attempt at surgical management, and that also unfortunately failed. But he said if there was some way to reroute the blood away from the heart during that procedure, then he was thinking that this could be more successful. So that led to the development of this machine, which I'm sure a lot of you recognize, the heart and lung machine, or the cardiopulmonary bypass. So his motivation for inventing this machine was actually for massive PEs. He wanted to find a way to perform that procedure successfully and for patients to survive. So that's a really significant step. And although the first time they actually used the machine, it was actually with open heart surgery, it was eventually successfully used for a pulmonary embolectomy, and that was by Dr. Stark, actually, Edward Stark at Johns Hopkins. So, and then from then on, Denton Cooley was involved as well, Dr. DeBakey. They actually had been investigating the use of IVC ligation to prevent PE during that time. So they were getting, it was a lot of desperation in how do we prevent these terrible things to happen in the OR, and they tried ligating the IVC. They also tried ligating the proximal femoral arteries. Those had a lot of complications, but they ultimately were successful in a few cases. So, but the development of the cardiopulmonary bypass really revolutionized that procedure. Dr. Hastings is just coming in now, so we're going to back up really quick and show him, our motivation behind all this, which is this massive thing right here. So I appreciate you sharing that with me. So as we go forward, what are some other reasons why we care about furthering the management and diagnosis of pulmonary embolism? So number one, it is a major cause of cardiovascular mortality. It's actually the third biggest cause of cardiovascular mortality, with around 100,000 case, or 60 to 120 cases per 100,000, and an estimated 60,000 to 100,000 deaths in the US alone. Like we said, it's the third leading cause of cardiovascular death, with the associated mortality you can see here. And even after someone survives, 50% of those patients will go on to have a post-pulmonary embolism syndrome, which we'll talk more in depth about, and can have a large impact on their quality of life and their comorbidities afterwards. Then there's also, other complications that include recurrent venous thromboembolism, and then a phenomenon known as chronic thromboembolic pulmonary hypertension, which we will also discuss a little bit more, that is being, developed, and the purpose of preventing that terrible consequence from this is something that I believe deserves a lot of attention, and we can talk more about that in a minute. So, when we're backing up and we're just talking about the initial diagnosis of a PE, there's some algorithms that have been processed and refined. So we have a good flow chart here that's kind of taking us through an algorithm for diagnosis. Now we have negative, probability, low to moderate, and then high probability, and that will determine what test will be beneficial and actually lead you to the diagnosis effectively, because this is a notoriously difficult diagnosis to make because patients present so variably sometimes. And so you can see that using the Wells score and things like that, you can determine when D-dimer is of use, when it is not, and then when you need to obtain chest imaging and to confirm the diagnosis, although that is not required. So, there is also a sign on ultrasound. Ultrasound of the heart can tell you a lot, especially with a massive PE. Can any one of the junior residents tell me a sign on ultrasound that is named that will give you a very high specificity for a massive PE? And it's something you may come across. I've come across it in real time in the hospital seeing a consult. What was that, Hannah? McConnell sign, yep, you're exactly right. So McConnell sign is a phenomenon where the heart is under so much strain from a massive PE that the apex of the heart is hyperdynamic and the lateral walls are akinetic. And so that sign on a ultrasound of the heart gives you around 95% specificity for a massive PE, and you can treat a patient based on that. It's very, although it is less sensitive, but it is very specific. So there was a time when I was seeing a consult on the vascular service at night, and I happened to go in the room while they were doing the cardiac ultrasound, and the tech immediately looked at me and said, "This patient has a McConnell sign," and it turned out exactly like we thought. So it is something that is important to note and can play a role in the diagnosis, especially in a patient that is decompensating quickly, and you may not have time to obtain an extensive workup. So other diagnostic tools that you use, obviously your physical exam will tell you a lot, the patient's history will tell you a lot. The PERC system, the Wells system, and the revised Geneva system all play a role in this. That includes exam findings like unilateral leg swelling, tachycardia, history of immobilization, previous PE, things like hemoptysis. All of those things can play a role in the diagnosis, including age. So once you have the diagnosis of PE, then you have to decide where does this patient stratify in the risk profile, and that is going to lead you to what the treatment would, the best treatment for that patient would be. So when determining the risk stratification for a patient with a PE, there's two large scoring systems that have been simplified and found to be relatively effective. That's the simplified PESI scoring and the BOVA score. So this is a good flow sheet that kind of outlines using the simplified PESI score, what that will mean for the patient's treatment. So a score of 0 means essentially just outpatient management with direct oral anticoagulants. A score greater than or equal to 1, including a blood pressure, systolic blood pressure greater than 90, will lead you to further working up to determine whether this patient is intermediate high risk or intermediate low risk. So that includes obtaining things like an echocardiogram, cardiac biomarkers, and that sort of thing. So that will then lead you to a further stratification of what treatment is right for the patient, and we're going to go into that a little bit more. So just to give you an idea of what goes into the PESI score, it's largely patient characteristics including age, medical history, including history of cancer, chronic cardiopulmonary disease, heart rate, systolic blood pressure, and then oxygen saturation. The BOVA score is also frequently used. You can see largely similar things, but cardiac troponins are included in that, and RV dysfunction on an echocardiogram or even a CT can be used in that scoring system. So when we talk about the risk stratification and what that means for management, we classify these into low, intermediate, and high risk. Intermediate can be further classified into intermediate low and intermediate high. And as you see, really the difference between low and intermediate and high is the finding of RV dysfunction or strain on the heart and hemodynamic instability potentially. That will further stratify you into intermediate or high risk. So elevated cardiac biomarkers are also used for that, including BNP and terminal pro-BNP and troponins. And then it leads you to whether the patient is hemodynamically stable or not. So transient hypotension will give you an intermediate risk, intermediate high risk, and a persistent hypotension will give you a massive PE or high risk PE, which is a sustained hypotension greater than 15 minutes in shock or on vasopressors. And so we can see then, the starting of our treatment algorithm with immediately with unfractionated heparin for intermediate and high risk, and then low molecular weight heparin for low risk. That also, for intermediate and high risk, we're going to talk about the role of thrombolysis as well as embolectomy and even ECMO therapy to rescue patients. So this is just kind of to review that risk stratification in a little more detail. Like we said, we're going to break it up into high risk, intermediate, which is stratified into two separate categories, and then low risk. So to make the distinction between intermediate high and intermediate low, it's going to be mainly elevated cardiac biomarkers and evidence of right heart failure, both of those. If you have one of those along with being hemodynamically stable, that puts you in the low risk category. So if you are stable and have both of those findings, that's going to put you into the intermediate high risk category. And so just to go over, what is the physiology that's happening during something like this, especially with a intermediate and high risk emboli, and that's essentially a large sudden increase in RV afterload. And so what that does is make the heart compensate for that increased afterload, and that compensation is very important to know how you manage that patient, when they present acutely. The number one thing to learn in this is that you always try to avoid intubating a patient who you suspect is having this physiology. As soon as they have positive pressure ventilation, their preload will dramatically decrease, and they will likely code at that point and lose the ability for their heart to continue compensating. I've actually seen that clinically here in real life, and it is a very terrible thing to witness and something that can be prevented, absolutely. And I do think that brings into the role for ECMO in a patient that is having respiratory distress and compromise. It is a bridge to a therapy that removes the intubation from that initial algorithm. And I think that's very important, and that's something that it will provide a lot of benefit to patients who are going through this. So before we get into the more advanced therapies, let's talk about how these patients were managed medically. We talked about the surgical, how the surgical procedures were developed and their history behind those. But initially, the first anticoagulant that was utilized for these patients was actually a compound known as Hyridin. Now, that was only being able to be administered by leeches that were physically applied to patients' skin. And so I know all the patients hate having Lovenox shots, but I'll tell you, it's a lot better than having leeches all over your ass, that's for sure. So. But anyway, apologize about that. But anyway, so then heparin was discovered shortly after that, and heparin became the mainstay for treatment, as at least medical treatment for patients and their anticoagulation. That is further developed into DOACs, or direct oral anticoagulants, that now also are very effective and are much better tolerated and easier to give outpatient as well. So going forward, we get into some trials where now the thought process is and the next step was developing thrombolytics, and with thrombolytics came a lot of risk for the patients and side effects. And so the thought process is, how do we determine what is the safest therapy for the patient and what is the most effective? The PITHO trial was a very important trial, the largest randomized trial actually in this setting, that looked at tenecteplase versus heparin, tenecteplase plus heparin versus just heparin alone. So this is looking at, are these systemic thrombolytics safe, and are they better than just giving the patient heparin? So when looking at the outcomes for this, there was no difference in the 7-day mortality in an acute setting. There was a significant increase in the major bleeding associated with the systemic lytics, as well as intracranial hemorrhage and extracranial bleeding. But long-term follow-up indicated no difference in the 3-year mortality for both groups of patients. So that kind of started to illustrate what we know now, where these systemic lytics have a high risk of bleeding complications. Now there's actually a PITHO-3 trial that is currently in process, which is looking at lower dose alteplase systemically, whether that still will result in the same risk factors and risk of bleeding. So that's something that will hopefully be coming out shortly, and I'm interested to see what that looks like, because in this was the highest dose used of tenecteplase, and so obviously that would likely carry the highest risk. So when looking at some meta-analyses and results for thrombolytics versus anticoagulation since then, a lot of the, when thrombolytics are successful, the outcomes definitely favor them. And so I think that plays into the algorithms currently that are used, whereas if the patient does not have risk factors for bleeding, immediate systemic thrombolytics for massive PEs is the current recommendation. And we'll talk about how that is in flux right now, but that has historically been the recommendation. Because if you stratify the patient appropriately based on their risks, they are extremely effective at reducing afterload on that RV and improving the patient's hemodynamics. And you can see that with this chart here. So the next level, kind of investigation involved lytic catheters. So obtaining a catheter or technology to deliver lytics directly to the source of the problem. The high PITHO trial, along with the PERT consortium, was an important way to look at this, and they actually haven't completed their investigation yet. It's ongoing at this time. But they were looking at a special catheter called the ECOS catheter, and that plus anticoagulation, did that confer the same bleeding risk and give the same benefits that the systemic lytics were? And if so, there wouldn't be a real reason to do the systemic lytics. Although, in my opinion, being able to administer something quickly in the ED without needing a procedure is probably going to be adding some benefit in patients that don't have bleeding risks. So that may be difficult to tease out, and I think that's what they're going through at this point. But so when we can talk a little bit more about catheter-directed therapies, because that's largely where this treatment algorithm is moving towards. So like we said, they reduce bleeding by targeting the clot directly, unlike the systemic version. And this includes both catheter-directed thrombolysis and mechanical thrombectomy, which is the newer version of a catheter-based therapy. So they're finding now that this is effective for both high risk and also intermediate risk pulmonary emboli. We can talk about the mechanism where the drugs are delivered straight to the clot, or the clots are physically sucked out of the artery and vein themselves, okay? So when talking about an algorithm for determining which way you're going to go, we talked about the current recommendation from the American Heart Association and a lot of cardiologists is going to be high-risk PE without contraindications to systemic thrombolysis. That is the best step initially. When there is any contraindication, which a lot of our patients do have contraindications, like recent surgical procedures or other bleeding risk or intracranial hemorrhage and trauma, then that is off the table and you have to move to the next best therapy, which at this time is coming out to largely be mechanical thrombectomy, and we're going to talk more about that. But we see here there's a lot of different options for both the catheter-directed thrombolysis and the embolectomies, and we're going to go through a few of those today. So, that next step, like we said, was determining the catheter-directed thrombolysis. Is it superior to anticoagulation alone? And we already kind of went through that. Yes, largely, the meta-analyses revealed that it was more effective, especially for intermediate and high-risk emboli. So, and when especially looking at older individuals, 65 to 99 years old, for both those stratified groups, all-cause mortality was improved with catheter-directed therapy versus systemic lytics and also just anticoagulation. So this was a specific pooled trials that looked at CDT versus just systemic thrombolysis and not only just anticoagulation. And it did find a lower mortality, lower intracranial hemorrhage, and lower major bleeding and transfusion requirements. And so that was a good step in the direction towards moving to catheter-based therapy. So talking about the ECOS catheter, which we mentioned, this is actually a very fascinating technology that involves both ultrasound waves and infusion of the lytic itself. So the catheter is essentially two components. The ultrasonic core is thread through the middle of the catheter, and the lytics are infused around that ultrasonic core. So that catheter is advanced up to the inside the clot itself, and then activated to promote dissolution and of the clot in that location. When talking about some mechanical thrombectomy devices, the Inari FlowTriever is one that has been around arguably the longest and used most reliably. So this is a very fascinating catheter where essentially it involves an aspiration technique along with a maceration stent, which we're going to see here. So not only can you aspirate the clot, you can also deploy the stent to macerate and assist with that aspiration as well. There's also a component that can go into this called flow return, where the issue with this largely was the blood loss associated. Obviously this is a very high velocity vessel, and so any aspiration is going to result in massive blood loss through this catheter, which is usually large bore 16 French. And so the way they mitigated that was allowing a flow return mechanism where the blood that's aspirated is then returned back to the patient via like a femoral vein access. Now, the only controversy with that right now is they're finding that that blood that's being returned may not be the same as normal blood and may actually cause harm to the patient because of the chemicals released inside the blood during this process, the destruction of the red blood cells and other cells in the blood itself. So they're finding that actually this blood return process, it may not be as beneficial and may actually be harmful. So that led companies to looking for other ways to get around the same problem of massive blood loss associated with these procedures and not actually harming the patient by trying to return it. And so the Penumbra Indigo system is one of the newer therapies that has shown a lot of promise with this, and it essentially uses a computer-assisted vacuum device where the system itself detects when the catheter is up against a clot versus just in the vessel itself with no clot attached to the end of the catheter. And so it will automatically sense and aspirate as the catheter is advanced to the clot, and when the catheter is past the clot or the clot has already been retrieved, then it immediately stops the aspiration and limits blood loss in that way. We use this here, and it has shown to be effective and has shown to limit blood loss compared to other systems. Although all of these systems have their pros and cons, and also user errors and user comfortability. So, but this has shown a lot of promise with those issues specifically. I'd like to take you through a case that happened at the hospital here that I was fortunate to be a part of, that I thought illustrates how successful and how amazing these new technologies can be in this disease process. So a patient presented to the hospital with a massive pulmonary emboli with the contraindications to systemic thrombolytics. Initial angiogram showed this picture here, which you can see significant likely saddle embolism, and after using the Indigo suction thrombectomy device, this was our post-procedure angiography, which you can see a significant improvement and major all the branches of the pulmonary artery. This was the actual clot that we were able to retrieve from that case itself. And so you can see this happened in a process of approximately 30 minutes. So, I think that's incredible for a process that can kill a patient so quickly. We've now developed minimally invasive techniques through a stick in the groin that can save a patient in 30 minutes or less while limiting blood loss. So the next catheter that we talk about is the AngioJet. Now this has largely been used for thrombolysis and thrombectomy, but it hasn't always been used for the pulmonary emboli, and it's not technically used for that specifically. It's used for peripheral thrombectomies. But it has actually, so now it is approved to use for pulmonary emboli. It is just not one that is used as commonly. It is a very interesting mechanism though. It utilizes a rhodiolytic mechanism with the Venturi-Bernoulli physics to use high-pressure saline jets to dissolve clots, and then a suction capacity to then aspirate them. And so that is shown to be very effective, and they're in the process of developing this for PE specifically. So to review the current indications for specifically mechanical thrombectomy in PE, that includes high-risk PE with contraindications of thrombolysis or failure of thrombolysis, intermediate high-risk PE with evidence of RV dysfunction and elevated biomarkers, submassive PE with clinical deterioration despite anticoagulation, patients with a high bleeding risk where thrombolysis is contraindicated, like we said, and a persistent hemodynamic instability after an initial thrombolytic therapy. So this has largely been determined based on registries. It's difficult to perform randomized controlled trials that give you this data, especially with massive emboli where patients come in unstable. That's a situation that is difficult to flesh out with randomized controlled trials. And so, but we have seen some very promising data with these mechanical thrombectomy systems in these registries. And you can see here that it lists some of those with intermediate change in mean pulmonary artery pressures, change in the pulmonary vascular resistance, patients with decreased supplemental O2, and then with very few major adverse effect or mortalities. And so that's really an incredible development. We'll talk about one almost arguably even more important benefit from these, and we're gonna mention that towards the end of the presentation. So the FLAME trial was one that was very significant, especially using the FlowTriever for a massive pulmonary PE. This really showed us that these devices are safe and effective with massive PEs. And you can see that all the endpoints were very significant. In-hospital mortality was decreased. Major bleeding was significantly decreased compared to the lytics. Also it improved bailouts or alternative therapy. And that usually means like systemic therapy or systemic catheter-directed lysis would be unsuccessful, and the patient will ultimately need to be bailed out to either a large surgery procedure with an open embolectomy or something like this, which could save the patient from needing a sternotomy and large surgical procedure. So the FLAIR trial then went on to investigate the intermediate risk patients and said that large bore mechanical thrombectomy was successful in reducing RV-LV ratio at 48 hours and also having an extremely low major bleeding rate. Now, the controversy with this, and along with other trials we'll talk about, is that the challenge is translating this to a clinical benefit for the patient. Although you have benefits that you see on an echo or see on a CT scan, it was unsuccessful in flushing out whether there was a specific mortality benefit and things like that. And so that's where this research is trying to get to now. The Peerless trial was another very significant trial that looked at intermediate risk PE. And we can see that the focus is really transitioning towards the intermediate risk PE. You know, where is that? What benefits are we going to get with those patients? And is it necessary to do procedures on them, or is heparin alone sufficient, and is all this unnecessary? So that's where a lot of the data is going now. And so they specifically found no significant difference in mortality, specifically intracranial hemorrhage or major bleeding using the mechanical thrombectomy. They did find lower clinical deterioration and bailout, like we talked about in the prior study, reduced ICU utilization, which plays a role in mitigating the cost differences between the two, shorter hospital stays also mitigating the cost, and then that similar RV-LV ratio reduction. So overall, a very positive trial for mechanical thrombectomy, but again, trying to translate that to a clinical benefit and also elucidating the financial aspect of it as well, which we'll talk about. The STORM PE is actually the most recent of these trials, and it is the first actually randomized control trial. Again, not necessarily looking at massive PE or high risk, but again, intermediate high risk pulmonary embolism. And so they found a superior reduction in RV-LV ratio at 48 hours, and it is comparable safety to the anticoagulation in that arm. That actually was completed this year, and so will be presented at the big vascular meetings throughout the year. So very promising. They specifically used the Indigo system for this trial. And so, like I said, it's a big deal because it's the first real randomized control trial that they were able to show the same results. So let's transition a little bit. We talked about the technology. Now let's talk about how this really works in a hospital system in real time. And so this has developed into what we call a PERT, or a response team activation. So that largely looks at a patient when this is identified in a patient, there is a process that's activated that pulls in all the team members that will be caring for the patient to make the right decision. And there was a 2025 meta-analysis that found a lot of benefits from having a system like this in place, including lower all-cause mortality, lower major or clinically relevant bleeding, higher utilization of advanced therapies, and reduced hospital length of stay. So based on this meta-analysis, they concluded that this should be the standard of care for patients with PE, and if your hospital is treating patients, this should be the standard of care at your facility. Fortunately, we've been using a system like this since 2019, which Dr. Hastings and our vascular surgeons and other cardiothoracic surgeons have played a role in. It also includes critical care, which will be involved, sometimes anesthesia, sometimes interventional radiology. All the people that play a role in the management of that patient at the hospital will be involved in what is sometimes a group call, or potentially a meeting in the hospital to determine in a short amount of time where they stratify that patient and what is going to be the best option for them. So this is one thing I wanted to talk about. Obviously mechanical thrombectomy, the technology is amazing. It's very effective, but it obviously does have a much higher cost associated. You can see here a median cost of $59,000 versus a $19,000 for a catheter-directed therapy. Is a pretty significant difference. But the way that this is mitigated, and to me, is that your hospital length of stay, your ICU length of stay, all of those are significantly decreased with mechanical thrombectomy. And so I think that will very easily make up that cost benefit, especially in an ICU setting. And arguably the important part of this was not even what they meant to look at, but the development of that chronic thromboembolic syndrome in mechanical thrombectomy patients was 0. So all of the other groups resulted in patients developing that syndrome down the road. And we'll talk about why that's such a big deal and why treating that condition is a very difficult process. And so it's very significant that literally none of the patients that underwent mechanical thrombectomy developed this syndrome. And we're going to get into it right now. So it's just a short intro into chronic thromboembolic pulmonary hypertension, basically characterized by unresolved thromboembolic occlusions of the pulmonary arteries. And this leads to pulmonary hypertension, right heart failure, and potentially death. And because this is a chronic finding, there is very few acute treatments that are going to resolve this in a patient. The heart at this point has had this chronic failure that is going to be very difficult to treat. And so that's why recognizing this and preventing it early is very important. The incidence is approximately 3% for patients that develop an acute pulmonary embolism, and it's largely made with VQ scanning and right heart catheterization to confirm. So the procedure that is suggested for this and has been developed starting in San Diego in the mid to late 1900s is a pulmonary thromboendarterectomy. So this is offered for patients that are operable, meaning deemed to be operative candidates, and can offer a potential cure with a perioperative mortality of around 2% at expert centers. It historically was much higher than this initially, but has been developed and basically at expert centers such as Duke, I think does this, and a lot of the high academic centers like Johns Hopkins have gotten very good at this procedure and have surgeons that do this very commonly. And so it's been optimized. For inoperable cases, options are balloon pulmonary angioplasty, and then medical therapies like guanylate cyclase stimulants like this medication that I'm not going to even try to pronounce. So there are medical therapies and percutaneous therapies available, but they haven't shown to be as effective as the operation itself. You can see here, this plaque looks much different than the plaque we saw in the acute setting. This plaque is hardened into the walls of the artery and almost become one with the intima. And so a suction thrombectomy device is not going to be successful at separating this from the wall of the artery and without significantly damaging and placing the patient at significant risk. So when we talk about CTEPH management and the surgery, we mentioned the 2% mortality at expert centers. These are all done with multidisciplinary teams, including heart failure teams, pulmonology teams, as well as the surgical teams. And the better we get at this procedure, the more distal we can remove clot. And that's important because the more clot that's removed, the better that patient's hemodynamics will allow and the best chance of recovery if there is room for any. We did talk about the multimodal approaches, including the balloon angioplasty and the medications as well for cases that are not operable. I think, I think we've already been through a lot of these, minimally invasive techniques. So we'll move on from there. And that's, now we just have references. So I'd like to take any questions or comments.
Thank you so much, Dr. Whitson. Excellent presentation.
Thank you.